Welcome back. This session is sponsored by Dose Logics. It is my pleasure to introduce our speakers, Dr. Heather Quayle and Dr. Tara Thompson, for this session. Dr. Quayle earned her undergraduate degree in psychology from Loyola University in Maryland and a second bachelor's in nursing from the University of Central Oklahoma, a Master of Science in Nursing with honors with a specialty in women's health from Vanderbilt University, and a Doctor of Nursing Practice from Chatham University. Heather is the co-founder, co-director for the Emory University Sexual Health Certificate Program and also maintains an adjunct faculty position at Vanderbilt University School of Nursing. She sits on the Georgia Human Trafficking Task Force. She is widely published in the field of women's health and regularly lectures to local and national audiences. She is also heavily involved in legislation and lobbying at the Georgia Capitol on issues affecting advanced nursing practice, human trafficking, and sexual assault. Dr. Tara Thompson earned her biomedical science degree from Texas A&M University and a doctorate of pharmacy from the University of Houston. She is the VP of Clinical Services at Innovation Compounding Pharmacy in Northwest Atlanta, Georgia, and specializes in women's health, specifically sexual health and pelvic medicine. Her day-to-day includes researching and developing patient-specific drug therapies and collaborating with clinicians and patients across the U.S. who are interested in or presently using compounded medications to treat women's health. Heather and Tara's complete bios can be found in the Speakers tab in the left-hand menu. Please join me in welcoming Dr. Heather Quayle and Dr. Tara Thompson.
Hello, everybody, and welcome to our presentation titled The Pharmacist, Provider, Patient Triad, a Multidisciplinary Approach to Patient Care. My name is Tara Thompson. I'm a pharmacist with Innovation Compounding Pharmacy, and I'm the VP of Clinical Services here at Innovation. And today I'm here with my colleague.
Hi, my name is Dr. Heather Quayle. I'm a women's health nurse practitioner, and I have my own practice, the SHOW Center, which stands for the Sexual Health Optimization and Wellness Center. I'm very, very grateful and honored to be here with my esteemed, wonderful colleague, Dr. Thompson.
Thank you guys so much for having us. Today we wanted to come to you guys with a joint presentation that both of us are going to kind of tag team and go through, because we do work together in the healthcare field and we truly believe in that multidisciplinary approach to patient care to achieve optimal results for the patient. So of note, myself or Dr. Quayle do not have any conflicts of interest related to any portion of this presentation, including any grants, gifts, stock holdings, employment, or honorarium as it pertains to what you'll hear today.
So today, this presentation is really going to highlight, as Dr. Thompson said, the importance of a multidisciplinary approach to patient care. We're going to talk about the importance of the pharmacist in the collaboration with the patients, the providers, and the caregivers as well. We're going to be building a foundation of trust and knowledge between the pharmacist and the provider, which can ultimately lead to a very positive patient outcome and more comprehensive approaches to their health. We're also going to highlight the role that the pharmacist plays along with the provider and the different skill sets that each of them can bring into the table. So in the healthcare landscape, as we looked about it, as an unsustainable healthcare costs keep persisting and money keeps being a big issue, stakeholders are ever more focused on just the value in what comes to the table. There's been increasing healthcare costs that have typically not resulted in improvements in quality, and it may be related to inefficiencies and variations in care delivery that is poised to facilitate quality improvement, cost savings, and collaboration among providers. So in this environment, there are three related trends that are shaping the market today. And those are patients are becoming more engaged in the healthcare system as consumers, and as a result, they want better care for their own health. They want transparency of their healthcare plan. They look at provider ratings, and they want great exposure to the true cost of care. The value imperative requires a clear understanding about how each type of healthcare provider, whether it's a healthcare provider, a pharmacist, ancillary services, allied health providers, can contribute to a more cost-effective patient care relationship. And so that's what we're going to be focusing on today when we talk about this changing healthcare landscape.
So the patient-provider-pharmacist relationship is nothing new. This has actually been going on since the beginning of time, back to Greek mythology even. So this picture here shows some of the earliest days showing the group effort for patient care. You can see in the background, you have a pharmacist who is mixing the medication there. You have your guy in the red cape. That is actually the physician, and he is consulting some medical text alongside the pharmacist. All the way to the left, you have your patient who is being attended to by Hygeia, who was the patron goddess of pharmacy. And that's whose name we get the bowl of Hygeia, which is the symbol of pharmacy, which we know. All the way to the right, you have her dad. Hygeia's dad was Asclepios, and he was the Greek god of medicine. So he's also looking over this scene, leaning against a bust of Hippocrates. And that's whose name we get the rod of Asclepius from, which is a symbol of medicine. And you can see that there in his hand. So since the beginning of time, we have been working together as a group to help the patient. The pharmacist, the physician, everyone's coming together as a team, figuring out the answer. And just as a reminder, these are the medical sort of symbols that have came from both the patron goddess of pharmacy, Hygeia, where we get the bowl of Hygeia, and then the rod of Asclepius comes from the medical profession from Asclepios. So just sort of knowing our background, that we were meant to work together, and we were all meant to be pushing for the greater good of the medical profession and the patients. So I want to talk a little bit about this slide. This is one of the pinnacle slides, one of the pinnacle shapes that we all think of in medicine, and it's that perfect triad. It's the patient, pharmacist, provider triad relationship that is so important to make the end outcome work correctly and to get that patient exactly what they need. The most important aspect of the pharmacist-provider relationship, this bottom part here, this connection is communication. It is so important to be in communication constantly between the pharmacist and the patient's provider. We'll see in a couple slides later that the patient actually sees the pharmacist more times throughout the year than they will their provider. So it is our job as pharmacists to keep that relationship open with the provider, and the sole reason that Heather and I brought this presentation to you today. Pharmacists and providers are the vital link between the patient and their entire healthcare system. So the patient we as pharmacists and their provider that we're working with may be the only link that that patient will have to healthcare. So we're the ones that will keep them sustained with what they need. We are uniquely positioned to complete the triad of care via communication and collaboration with other healthcare professionals to bring comprehensive, well-rounded care. And all of this is uniquely relationship improved upon the following factors: communication, patient understanding, medication adherence, quality of care, and health outcomes. And we'll see some examples of these in future slides.
So I want to point out the American Association of Nurse Practitioners, and that is a guiding philosophy for many, many nurse practitioners, the AANP position statement. And what that shows is it actually really encourages and supports this collaborative relationship between a multidisciplinary team, i.e. pharmacists, providers, ancillary health. And they really help in the approaches to coordinate care health delivery, and they're centered on the actual patient's needs, letting you provide from all different aspects. And this is also consistent with the National Academy of Medicine's, or formerly the Institute of Medicine's, definition of what they call team-based care. As we can see from the blue part of this, team-based care is the provision of health services to individuals, to families, and their communities by at least 2 different healthcare providers. Again, whether that's a pharmacist and a provider and a physical therapist, a pharmacist and another allied health provider, and they're going to work collaboratively with the patient as well as with the patient's caregivers. And that is to the extent which is preferred by the patient. So again, when you think about this team-centric approach, it's really important to kind of look at patients in the middle of it. And if you make a circle around it, where does that team fall around with the patient being the center of care? So to accomplish the shared goals within these settings, they're looking for high quality care. And part of it with that National Academy of Medicine, it's part of their core principles and values of an effective team-based healthcare approach. Team-based healthcare as defined by the National Academy of Medicine, again, is a system approach to care. It's not licensure. It's not a construct that needs to be licensed. It's taking a bunch of licensed providers, though, and using them in that healthcare team. AANP actually opposes laws and regulations that make it illegal for a clinician to practice to the top of their education, or that require licensure or regulation as a part of the team to practice. And that really impedes patients when there are such laws such as that. So again, we really are encouraging a very team-centric approach to care. Next slide, please. So what does this healthcare team look like? You heard me just kind of saying it's 2 or more healthcare professionals that are working to meet the patient's shared goals. We're going to begin by asking a simple question. What does that team look like? Healthcare teams can be defined in looking at different literature as 2 or more people who work collaboratively with the patients to accomplish the goals. However, a healthcare team may involve a wide range of team members in various settings. Examples include small office-based teams consisting of maybe a primary care clinician with 1 or 2 medical assistants, or something like a hospital-based trauma team with dozens of members. Again, both of those scenarios could involve a pharmacist. A very small practice could involve a pharmacist where prescriptions get called in, you're working collaboratively with the pharmacist, or of course in a big hospital-based system where they actually have pharmacies right in the hospital setting. In addition to patients and their support groups, potential members, again, besides physicians and pharmacists, may include people like nurses, social workers, trainees, and others that are identified as people that are necessary to achieve this shared team-centric approach. The fundamental concept is that a team is a group of individuals that are going to coordinate their care and their actions for a common purpose for the patient, which in the healthcare system is prevention or treatment of disease and promotion of health, which are all those optimal goals. A team-based model really strives to meet the patient's needs and their preferences by actively engaging patients as full participants in their actual care, while encouraging all healthcare providers to function to the full extent of their education, their certification, and their experiences.
So we talked a little bit earlier about how patients in general, how pharmacists and their provider may be their essential link to healthcare. I pulled some statistics from 2019. I wanted to go pre-pandemic because after the pandemic, these numbers will definitely be different for that year that we basically didn't leave our homes. But in 2019, from this particular study, the average adult was shown to fill about 12 prescriptions, both new and refills, per year. After the age of 65, that number will shoot to an average of 30 prescriptions annually. So I wanted to put those numbers up just to show you that the patient is coming back and forth to the pharmacy. The pharmacist is very important in that care, but the provider doesn't necessarily know if the patient is going back for those refills or filling the prescription in general. Maybe they didn't get it for a couple of months. That is where it's so crucial for us as pharmacists to speak and have that open line of communication with the provider. A study also showed that pharmacists reduced physician burnout among primary care physicians and helped benefit their work life through the following 7 outcomes. Pharmacists provided a decreased workload for the provider. They provided that satisfaction that patients were receiving better care if the pharmacist was involved in that patient's care. Reassurance for the provider, sometimes just that reassurance that there's a pharmacist in the background that's managing those refills, that's having their patient come in and get counseled, can definitely reassure the provider a little bit and decrease a little bit of that burnout. Pharmacists also help decrease mental exhaustion, which goes into that reassurance as well. Enhance the professional learning of the provider. I thought that was a very interesting one. We're constantly, as pharmacists, we're always deeming ourselves the drug experts. Well, let's share that knowledge with our providers. Let's enhance their professional learning. Let's talk to them about dosing, about strengths, about drug-drug interactions. Pharmacists helped increase provider access and also help them achieve their quality measures that they were looking for in the patient. And we'll see some examples later about some MTM, medication therapy management, examples where those quality measures were hit so much better once you brought a pharmacist on board and as a part of that healthcare team. So this just kind of harps on the first slide the slide I just talked about. But basically there was a study done in 2020 in JAMA, the Journal of the American Medical Association, where over 680,000 patients were put through this analysis to show the number of community pharmacy visits versus the number of encounters with their PCPs or their primary care physicians. And in all 50 states, except 9 counties, only 9 counties somewhere out there, the number of community pharmacy visits was larger than the number of encounters with primary physicians. So you can just see that patients are coming to talk to the pharmacist. They want to talk to the pharmacy. They want to know what's going on. They want their meds. They need help. They're looking for something over the counter. They're looking for help. So important that although they are walking into our pharmacies or calling our pharmacies, we still need to communicate that with the provider. And of course, as you can imagine, the difference is larger in the rural versus the metropolitan areas. So if your patients are in rural areas, they're going to their pharmacist a lot more than they are going to see their provider. And this will depend where you live. So you can kind of see where you practice and, you know, the differences in going to the pharmacy 4 times versus going to see their provider once. And that increases with depending on where you live.
So just as Dr. Thompson said, I'm going to kind of highlight a lot of things that she has just mentioned in here. Again, we're talking about this collaborative team-based care with the addition of a pharmacist helping healthcare providers. It really does help to alleviate the demand that's placed on physician or provider-centric care. And we're going to talk about that a little bit more as I go through how we utilize them in each step in our side of it between assessment, collaboration, and assessment and things of that nature. This team-based care is also can be facilitated by agreements and protocols. We have a relationship with pharmacists, but something can actually be established. So after you listen to this lecture, you may decide, never thought about it that way. And so it may be a way to kind of start things by developing some sort of an agreement or protocol with a local pharmacy and how they can help you with that. Next slide, please. So when we talk about team-based care, it's really kind of important to get into a little bit of the nitty-gritty around the philosophy. And part of that is to develop, communicate, and use practice philosophies, again, of that patient-centered team-based care. Some primary care practices have developed their own philosophies of what patient-centered team-based care looks like, and some of them have brought in input from patients from this. Hospitals, for example, may have brought in organizational leaders, team members, and other stakeholders. After developing the philosophy, a practice can use it to inform how to approach and how to adopt it in the delivery of care with the patient. And so that's where that also becomes important. It can help with evaluating the program and evaluating team-based managed care. Methods that some practices have used also accomplish the goal include you need to achieve buy-in from your leadership. So that can be in an office level as well as in a big hospital level as well. You really want to engage leadership in developing and reinforcing the guiding principles because it can help foster the adoption of principles throughout the actual organization. When you think of things, for example, one primary care organization leader emphasizes its philosophy of patient-centered team-based care in his orientation session with all new hires. So it's really important even talking about that early on before you hire people. Communicating the philosophy widely. Some practices post their philosophy of team-centered care throughout their offices, included in patient rooms, to continually remind patients as well as staff members that this is the organization's guiding principle. So just some kind of things to think about. Using the philosophy also helps to guide in decision-making. When you're making decisions about changes to care and design and delivery, practices can assess how well proposed these changes align with the philosophy and with the patient's preferences. You want to also incorporate the philosophy into human resource policies and procedures. Some practices have taken steps to maximize the uptake of these guiding principles by incorporating them into hiring, training, and also performances review processes. And lastly, you want to use language that reflects the practice's patient-centered philosophy and values. Several experts discuss the importance of thinking critically about the language that providers teams use to describe their work on patient-centered care teams. For example, you have a practice that may replace the word patient with either a consumer, a customer, an owner, and the practice does so to reinforce kind of a new way of thinking about relationships between providers and the people that we serve. Next slide, please. So what are some successful teamwork characteristics? You're all really looking to accomplish that same goal. And there's 4 characteristics that we're really looking for. You want a clear and compelling purpose or goal. Number 2 is you want to enable social structure that facilitates teamwork. Number 3, you want to support an organizational context. And number 4, you want expert teamwork and coaching. Effective teamwork depends upon the team members' psychological safety, and that's defined as their ability to trust one another and how safe enough within the team to admit mistakes, to be able to ask questions, to offer new data or a new skill set without fear of embarrassment, punishment, people looking at them crazy. It allows team members really to learn from one another and to teach one another, to communicate, to reason, to think together, and to achieve this shared goals. And it really revolves around just respect for one another, respect for each other as a team, as well as for the patient. Next slide, please. So I like to pull out this vision because it was put together by the Joint Commission of Pharmacy Practitioners. And what it looks like is that patients receiving optimal health outcomes, when you look at the team-centered approach that Dr. Thompson and I have been talking about. When you put the patient in the middle of that circle and you look at all the different colors on the wheel between collection, assessment, plan, implementation, follow-up, and medication management, all of those pieces can involve the whole healthcare team, specifically pharmacists, and how they can help us through each piece. Next slide, please. This is it in a much bigger picture so that you can see it better. Again, patient-centered care with collaborating, communicating, and documenting. The patient is in the center of that wheel, and even if you would want to say their caregivers can be in the center of that wheel. And then when you think of the spokes of the wheel, which are going to be the thin lines, that's where it's providers and pharmacists, ancillary health people, and other pieces of the equation. And so I'm going to go over a little bit about what that looks like in all these different processes as we collect, assess, plan, implement, and follow up and monitor and evaluate, and where the pharmacist and provider can work together collaboratively. Next slide, please. So when we think about collection, the provider is key in using communication and sharing components of the EHR, especially with their pharmacists. So the way the pharmacist can really work with providers on this is to assure that we're getting all the necessary pieces, the subjective, the objective information, and making sure that the patient understands that. Are we reconciling their medications? What's the current list? What does the list look like? Are there non-prescriptions, herbal products, things that are relevant to that? So that when we collect this data from the patient, we can then hand it over to the pharmacist if they have access, for example, in a hospital system. It's a universal electronic health record where the pharmacist may be able to go right on there and access those pieces of information. In a private practice, it's a little bit different because that's data that we're going to have to give to the pharmacist as we're filling things out. And that's where the pharmacist really can come in handy to reconcile those pieces. Next slide. So when we talk about the assessment, that's where they can look at the information that gets collected and to make sure that it's reaching the optimal goals for the patient. So for example, if I have a patient, I work in the field of sexual medicine, and that's where Dr. Thompson and I really align a lot on things. So when I need things to help in what I've assessed about my patient, whether I've realized that they may have a form of pain in their vaginal area or things of that nature. Sometimes I will call Dr. Thompson and say, listen, this is what I've assessed. This is what I'm seeing. What types of medicines may be appropriate for this patient? Like I have my laundry list, but that's where she can really kind of come in and help me look at maybe the appropriateness, the effectiveness, or the safety. Hey, this is her. This is how she looks. For example, I had a patient with a propylene glycol allergy, and I had to reach out to Dr. Thompson. Hey, can you actually compound this for me? What does this look like? Just because the patient had so many allergies, and that's a lot of times where I bring in the pharmacist in the assessment, looking at different kinds of status, their risk factors, their data. That's again where you can bring pharmacists into that, please. Next slide, please. So the plan, this is also again where the pharmacist really helps us make an individualized patient-centered care plan. We work with other healthcare professionals to do this. And like Dr. Thompson had said, a lot of times you get that fatigue or restlessness. We call it in our world compassion fatigue. We're working so much with maybe high needs patients, especially post-pandemic, that have a lot of maybe mental health things that they weren't having before, because obviously the pandemic caused so many issues for patients. My patients are very high need patients just because they've been to so many providers before they get to me. So sometimes you can get that compassion fatigue as a provider. And when I think that I may have kind of gotten to that point, that's again where I can bring the pharmacist in to really help with my plan and to kind of help with optimizing that, to help me get the patient realistic goals. And that is again where Dr. Thompson comes in for me. And once I pass my medications off and I've counseled my patient, they come in as the pharmacy and they help with the plan. Okay, your provider gave you this. This is what it's doing, and really kind of reiterates the plan again, so that again, it's very team centric. Next slide. So implementing, that's again where the pharmacist looks at the plan of care, they collaborate with the healthcare professional, and it helps to look at the different medicines. They help with initiating them, changing them. There's many times I've had to change different prescriptions where Dr. Thompson has come in and said, well, maybe try this, or how would this work, or modifying, helping me with, oh, has this drug maybe been discontinued? Let's try this, just helping with reconciling the electronic record. They're also involved in administering medications as well. Pharmacists have the ability, at least in our state of Georgia, and I don't know how it is across the country, but there are things that they can administer, such as immunizations and different types of shots and things around that nature, where you can also utilize them, especially in bigger organizations where everyone has a role. Bringing in the pharmacist into that piece with implementing them to give immunizations and other things is a great use for them as well. Next slide. In terms of follow-up, this is again where they are so useful. A lot of times once a patient gets their prescription, especially in the compounding pharmacy world, this is where they often see the provider sometimes more even than they see me. I may send a refill, but my pharmacist may be putting eyes on them more than I am. So they can really help them with monitoring and evaluating the different prescriptions that they're giving, and making sure that, again, are they working for you? Are they effective? Are they safe? Are you having any issues? And the pharmacist can come back back to the provider if the patient hasn't, and let the provider know, okay, this may not be working or this is working for the patient. And it really helps with outcomes of care as well as moving forward in the process of team-centric care. Next slide. So how do we apply this? Where is it applied? You've heard me kind of talk about it. It's applied in different situations, in a hospital setting as well as in a clinic setting. It can be applied to settings that use IV medicine. That's where the pharmacist can come in. They can make the IVs. They can bring them or ship them to your center, and they can help with pieces of that. They can help with looking at all the different medications that the patient is on. Sometimes the patients tell the pharmacist more than they tell us with their medication, because as we're asking them a million questions when they come to us for care, they may tell the pharmacist, oh, I forgot to tell my provider I'm on this. They're wonderful in helping with diabetes management. That in and of itself is a whole other animal, and the pharmacists and the meds are always changing, and that's where they also can help with reconciliation of meds. Where Dr. Thompson and I use each other a lot, quite is sex medicine, and that's why I put it down there, because she really specializes in compounding things that just can't be made over the counter that are very helpful in the plan of care for my patients.
Thank you, Heather. That's awesome to see all the different aspects of just working together as a team. I wanted to talk now a little bit about medication therapy management. This is somewhere that the pharmacist has such a huge impact on the patient's outcomes, but also the importance of relaying that information back to the providers. So as defined by the American Pharmacists Association, MTM, or medication therapy management, is a term used to describe a broad range of healthcare services provided by pharmacists on the healthcare team. So basically, pharmacists provide MTM services for patients by actively managing their drug therapy, by identifying, preventing, resolving medication-related problems. So duplications in therapy, drug-drug interactions, drug-food interactions. I talked with a patient this morning who I asked what his over-the-counter medications was, and he told me he was taking a multivitamin. And so I was like, okay, that's great. I wrote it down. I kept prying a little bit. I said, well, I think we need to get you some extra vitamin D supplement to go, because his levels were super low and he was feeling particular symptoms. And he's like, oh, I already take one of those too. And so as I spoke with him more and more, there just more supplements came up. Oh, I'm also, what was it? He was also taking like an iodine supplement. And then he was also taking, oh, I chew a vitamin C chewable too. He's like, I forgot to tell you that. So the more you kind of pry, and I know that the providers, they have a chance to do this, or they kind of ask people on their intake forms, but really just prying into the patient and getting a little bit more dirt, and you'll understand what more and more comes out. But anyways, that was a side note, just something I experienced today. But pharmacists can provide MTM services in all care settings in which the patient takes medication. So whether they're in the hospital, whether they're seeing private practice providers, whether they're just walking into your pharmacy and looking for certain supplements or certain products, is where we can sort of see what else they're on. So I wanted to provide a few examples of where medication therapy management was so beneficial. And the first one, these are all state health department ran MTM project examples. So the data is public and out there, but one of the most notable ones that a lot of us will just remember from hearing about in school or hearing about as one of the biggies is the Asheville project. And this is where employees of the city of Asheville who had conditions like diabetes, asthma, hypertension, high cholesterol, they received intensive self-management education through the St. Joseph's Diabetes Center up there. But the employees actually teamed up with their local pharmacist who ensured that they were using their medications correctly. It provided chronic care management through education, monitoring, follow-up, and referrals for patients with diabetes to providers for them. And it showed over the course that the study was done that pharmacists improved the clinical outcomes of the diabetes patients and reduced their overall healthcare cost. So an average net savings of about $1,600 to $3,300 per person per year was the average net savings that the pharmacist was helping save the patient. It also benefited employers who supported the projects. They benefited substantially by a 50% average reduction in the number of sick days of these patients, and also increased productivity. So 69% of the participants achieved their cholesterol goals when using a pharmacist on the team, and then 81% of them reached their blood pressure goals with the pharmacist on the team. So you can see here how important it is that we're working together, because ultimately when these patients are going back to their providers and they're having these better outcomes and they're staying compliant on their medication, people like Heather are going to come back to you and say, thank you for helping my patient, because you get to see them more often than I do. You get to tell them to refill their medication. So it actually makes that relationship and trust bond a little bit better. Here's another example. It was called the Diabetes 10 City Challenge. It's also a very popular one where employers were provided education and monitoring by pharmacists, saving average net savings of more money, over $1,000 per patient per year. A1C and screening rates being improved to 97%. And also in the preventative care realm, 65% of the patients were getting flu shots and 81% received foot exams. So just very important preventative care measures that can save in the future, save the patient's life and money. Other ones were the Maryland P3 program, where they put patient, pharmacist, and partnerships together, and the Montana Pharmacist Blood Pressure Management Program. So some great examples of MTM where it helped out patients.
So I think it's really important. Again, you've heard about it throughout, but one of the most important ways that I involve a pharmacist in my work is really through medication reconciliation. Small practices can use this as well as larger pharmacies. They really help us make sure, has the patient said all their allergies? Have they said all the medications they're on? Are there any interactions with the actual medication that they're on versus what maybe they have told us? Sometimes pharmacists will call me on the phone, hey, did the patient tell you they had X because you prescribed Y and that's an allergy? And so they really can kind of help keep us in check and make sure that there's no type of medication discrepancies. When there's comprehensive transition of care programs that utilize a pharmacist and a provider, medication reconciliation is really important, especially in post-hospital discharge situations, because it sets the patient up for looking at any kind of elevated risks or concerns that are there so that they can avoid hospitalization or rehospitalization again. Next slide. So when we look at preventative care services, providers can provide a number of screening services and giving themselves really a community presence. They can also serve as a platform for public health initiatives. So again, you heard me talk about ways that they can utilize giving vaccines, different types of shots that are available. It's really effective and really helps with just delivery of care, utilizing them in their communities. And it again shows where the pharmacist is really involved and is really part of the team, because they can give these simple vaccine services to patients. Sometimes it's easier than waiting forever to get into a provider. And especially if these things are established under protocol between patient, provider, and pharmacist. Again, a really great place to utilize them. Next slide. When we look at education and counseling, that's also a place where they can contribute to much better outcomes. Evidence shows that pharmacists can play a very important role in improving the overall health in areas, for example, such as tobacco cessation and especially in weight management. Pharmacists provide counseling can also be a key component in other types of pharmacy interventions that have been shown to improve outcomes. So again, diabetes education. Unfortunately, us as providers, we're very honed in on our skill set and what we can and can't do in the short time, especially in insurance-based models that insurance allows. So these patients get these quick, unfortunate 20-minute visits, and everything can't be talked about in that. But that's again where the pharmacist may have more time with the patient, because they don't necessarily have to follow insurance guidelines on reimbursement, where they can say, here, your provider may have educated you about X, but they can spend some more time educating them, especially around their medicines. And that also helps with just better compliance and better healthcare outcomes.
So let's talk a little bit about collaborative practice agreements, because this is really an area where the pharmacist and the provider can come together and truly work together to help manage that patient. So as defined by the American College of Clinical Pharmacy, ACTP, a collaborative drug therapy management is the collaborative practice agreement between one or more physicians and pharmacists, wherein qualified pharmacists are working within the context of a defined protocol and are permitted to assume professional responsibility for performing patient assessments, ordering drug-related laboratory tests, administering drugs, selecting, initiating, monitoring, continuing, and adjusting drug regimens. It sounds like a lot, but there's actually places in medicine where pharmacists and providers can work together to do this. So a collaborative practice agreement is actually a contract or an agreement that both parties agree upon between one or more healthcare providers and their pharmacist. It allows qualified pharmacists to perform those tasks based on what disease states we're looking at. So it might just be a diabetes management collaborative practice agreement. It might be a hormone therapy collaborative practice agreement, but that is decided on between the provider and the pharmacist. And it's usually between a provider and pharmacist who have worked together for a while or who have trust in. So you may be thinking, I don't have anybody that I work close with, or I don't know anybody on that level. Well, you'd be surprised, because providers actually want help with these types of things. They want help if there's a patient who might need a slight decrease in therapy, slight increase in therapy, that's performed, specifically for that patient. And of course, the communication lines are always open where you can go back and forth and figure out that patient's drug regimen. There are policy and law related considerations to take into account if you enter into a CPA with a provider. And this is authorized through your state scope of practice laws. So basically, it depends on your state whether or not, and I'll show you a map on the next slide that's really helpful, showing you the different laws for the different states and whether or not you have authority as a pharmacist to do these things. Some of the challenges with collaborative practice agreements are billing for services. So it's always kind of been like who bills what does who. But there's some really good resources out there that I have listed down here that are available from different organizations that help you and give you toolkits and resources to actually build these collaborative practice agreements, working together to develop terms, to develop billing and money, the business side of it. And also give you some guidelines on what pharmacists can do for a patient without stepping over the line of being that healthcare provider that's actually seeing the patient. So really great resources down there at the bottom to check out. So here's a map that sort of shows, well, it does show the different state and their CPA laws. And this is from the CDC. So they're constantly updating this. Here in Georgia, we have full authority to provide a drug therapy management as specified in a written specific protocol or agreement in any setting. So that's specifically for Georgia in the dark green. You can see other states where there's either no law really defined or it's unclear, or you have limited particular agreements that, or disease states really is kind of what it centers around sometimes of what you can manage. So it is important to check with your state, both from the provider side, either your nurse practitioner or your doctor, your DO, there's different stipulations for that, and then what you can do as a pharmacist. So just make sure you're checking. But those resources out there really help go over that very thoroughly. So let's talk about a little bit about the impact of collaborative practice. There's strong evidence that exists within this strategy that has different evidence of both effectiveness and of impact. So the health impact achieves, or the effectiveness evidence shows that you are achieving desired outcomes, both internally and external validity in your collaborative practice and the outcomes of these particular patients. There is also, it can be independently replicated. So that's the importance of a CPA in that. And then also the reliability of them. There is some economic impact. So research suggests that clinical pharmacies and clinical pharmacists who are doing services like drug therapy management and having these collaborative practice can be cost saving to the healthcare system, primarily through avoided hospitalizations and ER visits. So lots of impacts there. Oops, did I go too far? Yeah. So one of the examples of the economic impact of a CPA is in Missouri. So in 2006, Missouri's pharmacy assisted collaborative drug management therapy program resulted in a 12% decrease in any cause hospitalizations, a 25% reduction in ER visits, and a decrease in drug-related problems among beneficiaries after a year. So this program was also found to have a 2.1 to 1 return on investment to the state, which was an estimated savings of $518 per patient per month. So you can see how big of an impact economically having a pharmacist and a provider working together to manage that patient's drugs had on that patient per month. That is a significant amount of money saved. This is one of my favorite slides because Heather and I talk about this all of the time, but it's such a multidisciplinary approach to care. Sometimes as pharmacists, we think we're on this island where we're just helping these patients with their medication. And then I speak with providers who feel like they're on the island and they don't have any help and everybody's sort of trying to figure it out. But once you work together and start talking over that patient's case, or for example, grand rounds in hospitals when they're rounding on each patient and having the different members of physical therapy, occupational therapy, everybody's coming in counseling. You see such better outcomes for the patient because every piece of the puzzle is putting in their professional input and their help, and that's what the little pieces that we're missing. So whether that be healthcare providers in terms of actually the ones that are examining and seeing the patients, we pull in counselors, educators, and coaches all the time, whether it be marriage counselors, whether it be sexual counselors, religious educators. We are always bringing in those pieces of the puzzle because sometimes the therapists and the counselors are what the patient needs to see outside of taking their medication and seeing their healthcare provider. Social workers, support groups are also very important. Heather and I specifically work a lot with pelvic floor physical therapists. Huge piece of the puzzle. Heather can probably talk to that about that a little bit more. She's works alongside a few. So just huge piece of the puzzle that you also have to remember the ancillary care providers that are going into this relationship with us as healthcare providers. Very important piece of the puzzle. So when you're pursuing medication adherence initiatives, pharmacists should always remember to obviously facilitate that communication and those therapy changes with the providers. But there are also some other notable interventions that can be done. Face-to-face counseling is so important, especially in these days. Patients need that person to talk to. A lot of the times it's over Zoom, might be over the phone even, but having that face-to-face relationship with the patient is so important. Sending reminders is also very important, whether they be text messages, emails. Calls are always good, but electronic reminders are easy, especially for the younger populations that are coming up. And just some other notable interventions here that just help minimize adverse effects, but maximize patient compliance. 90-day supplies. We just did a study on this, how a 90-day supply can achieve more optimal patient outcomes than them trying to get it every month because maybe they're late or they forget. So little things like that always are benefiting to the patient, and also reminding your providers that you work with about these little tidbits of information that they might not think about. Hey doc, do you mind giving this patient a 90-day supply? It's a thyroid medication. They're going to be on it until they see you in 6 months. That way she doesn't have to call that often. That way, she doesn't have to remember. She doesn't have to pay for shipping again, just little things like that you would be surprised how providers are very amenable to your suggestions and your tidbits of help. And then, as always, we have to mention the challenges in team-based care. Sometimes it's at the patient's level. Not all patients are comfortable being much more active participants in their healthcare decisions. Maybe they just want to talk to one person and have that person, like Heather, manage their care. They don't want to bring in this big team. Sometimes just relaying that information of, we're all here to make you better, the best as you can be. So bringing in that physical therapist is important, but sometimes you have to let patients know about that a little bit. Patients will end up finding that their care is being delivered way more efficiently and comprehensively when you bring in every member of the multidisciplinary team. Reimbursement, we know, is always a challenge in team-based care. We don't have to, beat the gas out of the mule, but that is always been a struggle for pharmacy, always been a struggle for providers. Honestly, at the end of the day, if the patient's getting cared for, that is really the main goal. Leadership. So sometimes large physician groups have resisted to acknowledge that other healthcare professionals, such as nurses, such as pharmacists, are equipped to lead the team. So there has been several campaigns launched that partner with healthcare professionals, registered nurses, counselors, which have demonstrated leadership and innovation in the successful team-based coordination of care. And then regulatory barriers, as always, scope of practice laws are always out there. I just showed you the map of the states that they're just differing everywhere, but almost all members of our healthcare team experience some sort of unnecessary restriction as a result of either an outdated law or a change that's happening with COVID. We saw it. There's a lot of changes happening. So regulatory barriers are you have your emergency laws and things like that. So some of the challenges. And then here's the resources that we used today for our presentation. We really just wanted to say thank you to everyone and just let you know that, healthcare providers can work together ultimately for the benefit of the patient. That's what it's all about. So we thank you for your time today. If you have any questions, need any more information, want to hear something else, or have us expand upon one of these points, please feel free to contact myself or Dr. Quayle. We're always available to make this world a more collaborative place between providers. So Heather, do you have any closing points?
No, it's really, thank you so much. I'm honored to be doing this and to hopefully have you guys have your wheels spinning a little bit more on how you can make this happen.
All right. Thank you guys. You'll have a great day.
Hello, everyone. Wasn't that an amazing presentation? Thank you so much to Dr. Heather Quayle and Dr. Tara Thompson. We are now open for some Q&A, and we've got a couple here to get us started, but please remember, if you have any questions for our speakers today, please put them in the chat and we'll pose them for you and get answers to all those burning questions. So how do you find providers in your area that you can work with? Tara and Heather, can you help us answer that?
Yeah, I can probably take that one. Well, it's interesting because sometimes as pharmacists, just from my perspective, it's hard to remember that we can just use the resources that we have around us. So for instance, in Heather and I's situation, we've actually used to talk on the phone a lot, just as pharmacist provider talking about patients, and you sort of just make those bonds with people over time. And some of you are probably thinking about some of the providers that you talk to on the phone on a daily basis, or maybe you email communicate on a daily basis. And I think it's just using that relationship and building upon it, and not being afraid to ask that provider, that doctor, that nurse practitioner in our case, just asking them, hey, we talk a lot. I think it would be really cool to collaborate on this. Let's get some sort of meeting set up where we can meet as a team and talk about how we can further this relationship for the greater good of all of our mutual patients. And maybe that's a collaborative practice agreement. Maybe it's not. Maybe it's more of just a collaboration of your time and how you're going to communicate and organize that. But I say use the existing relationships that you already have. You would be surprised. I know it can sometimes be awkward or embarrassing to maybe ask a provider that question for fear of them saying no. But just you'd be surprised if you asked your providers that you talk to, hey, let's get a time to talk more deeply about this, because you'll come to see that they actually are very receptive of your help. They want your help too, and they need your help, and really just taking that first step, I think, with the current relationships that you have.
Thanks, Tara. Heather, anything you wanted to add to that?
I think it's just really important also, as Dr. Thompson had said, that you just want to make sure to reach out to your providers, but being a provider too, you also have to be receptive and willing to realize that we don't know everything. We can't expect to know everything. And so utilizing other people in your team, whether it's a pharmacist, a physical therapist, a respiratory therapist, maybe even another provider, it's so essential for the patient's care to involve them. And so having someone like Dr. Thompson in my arsenal, where if I'm maybe not sure how to do a particular medication for a patient, knowing kind of where my limits are and where she can help be an advocate for my patient, I think that's really important for us to think about as being providers.
Yeah, absolutely. I guess the question though is like, how did the two of you find each other? How do you initiate that relationship? You might find the providers, but connecting with them. Any suggestions that way?
I think you really find them by, I am a boots on the ground kind of provider. I will go, I'll knock on doors, I'll go meet people. I think part of it, and I've been listening to a lot of podcasts lately, because one of the big things I have is what I sometimes will call this imposter syndrome. I own my own practice and I'm like, man, I'm a nurse practitioner. I'm on my island. A lot don't own their own practice. What does this mean? And am I doing this? Can I really do this? So I get these self-doubts, but I was listening to this podcast, and I think it's appropriate for this question, is that sometimes we just have to get uncomfortable. You never get really good things until you get to a place where you get a little bit uncomfortable with what is the status quo. So if you know a pharmacist that you may have talked to on the phone, even briefly, that helped you with medication, send them a little note, send them an email, and say something like, hey, you helped me with so-and-so, this is great. How about we set up a time to maybe grab some coffee, a lunch, a Zoom, a something, and putting yourself out there. This is who I am. This is what I do. Tara and I had met because I was in another practice, and she happened to see one of the providers at my practice at a social thing, and it all kind of developed from there. And there were many times, just as Dr. Thompson said, we had talked on the telephone, and then it led to us talking more, meeting more in person, doing things together. We run a podcast together now, and we do a lot of things very collaboratively. And again, it's really kind of getting out of your comfort zone. Never in a million years did Dr. Thompson and I think we'd be doing a podcast on sexual health maybe 4 or 5 years ago.
Well, maybe it's time for a shout out on that podcast. Why don't you tell everybody what it is and how they can find it?
Yeah, well, sure. I mean, that'd be awesome. Our podcast is called Just Ask, and each month we get a new guest that is an expert in sexual medicine. So it may be a sex therapist, it may be a urologist, it may be an OBGYN, or even a trauma survivor, or something like that. And we bring them on and we let them tell their story. And no question is, too taboo, or no question goes unsaid. We just encourage patients to advocate for their health in terms of sexual medicine and women's issues. And so yeah, we're on Instagram. It's at Just Ask ATL, and then you can find us on any of the major podcast outlets. So
that's awesome. It's
one of the things
to ask questions with no judgment, and you're
yes.
An anonymity aspect. Sorry, go ahead, Dr. Thompson.
Yeah, no, you're exactly right. And patients, we run that together because we want patients to feel comfortable asking those types of questions. And we found really in the last, I would say 5-10 years, there has been sort of a shift for people speaking out for their sexual problems, issues. Maybe they're part of the LGBT community. Just so many different topics there. It's really fun. It's very conversational. But I was thinking when Dr. Quell was talking a second ago about collaborating together on mutual patients and that kind of thing is that her and I talked in the beginning, and now it's sort of a mutual respect. But we talked a lot in the beginning about boundaries and respect, and how knowing I am a pharmacist and that is my job and that is my passion, and staying on my sort of pharmacist hat and dosing and pharmacokinetic, pharmacodynamic, pharmacology level, and then not trying to treat a patient that I have never seen. Whereas Heather is sort of the opposite, and she's seeing the patient in person, she's getting all of that information, and she's reaching out to me when it's appropriate for her that to need some information. So always just keeping that level of respect with your provider as a pharmacist.